Well, good evening, everyone, and welcome to our Family Domestic Sexual Violence Clinical Spotlight series. Tonight, we are talking to you about understanding and responding to harmful sexual behaviours in young people. This is our second of 4 online education sessions across the Clinical Spotlight series on family domestic sexual violence topics. And these are running on the last Wednesday of the month over February through to May. So we've had one already last month, and tonight is our second. We're really pleased to have so many of our attendees dialing in live for tonight's session, and we know we've got many more who have registered for the session and will be able to access the recording. My name is Emily Leary. I'm the project lead at Western Victoria Primary Health Network on the Family Domestic Sexual Violence Pilot Project, and I'll be facilitating this evening. I also have support from colleagues here at the PHN, Jade Buller from the Workforce Development team, and also Sarah Hole from the Primary Care Projects team as well. So Western Victorian Primary Health Network acknowledges the traditional custodians and owners of the unceded lands and waterways from which we are gathering from this evening and to which we now know as Western Victoria. We pay our respects to elders, both past, present and emerging, and we recognise diversity, resilience and the ongoing place that First Nations peoples hold in our communities. We commit to working together in the spirit of mutual understanding, respect and reconciliation, and we do support self-determination for First Nations peoples and organisations. I do just want to say that we do have a lot of upcoming events that you can see there listed on the screen, and these are freely available on our PHN Learn YouTube channel. We'll put the link to access the recorded webinar events into the chat, and please just make sure you have a look at the upcoming events on the screen now. You can register for these on our website. Western Victorian Primary Health Network's biggest education event of the year is also happening in October this year on the 9th and 10th of October on a Friday and a Saturday at the Good Shed in Ballarat. We've got some fantastic speakers, keynote speakers locked in for this conference, and lots of impactful education sessions planned as well. Just to note that registrations for that will open in early July, and we will release more information about speakers and planned sessions at that time. Western Vic PHN's Learner Network newsletter is the best way to stay up to date with our latest education opportunities and upcoming events. So if you haven't received an edition yet, please subscribe via the link in the chat, or you can scan the QR code that's on the screen. Editions are released on the first Tuesday of every month. And just a reminder about Health Pathways, which is a free online resource. It's localised clinical and referral information for health practitioners. So important that you're familiarised with that. There's a link in the chat of where you can register for this as well if you haven't already. It's really important that we are able to issue you with a certificate of attendance after the session today. Just take a moment to check that your full name is displayed correctly on the screen. If not, just pop your name into the chat box. Your first and last name would be fine into the chat box now, and we'll ensure to issue you with a certificate of attendance. Just to remind you as well, tonight's session is being recorded. However, only the didactic component is being captured through the recording, and we will stop the recording when we enter the case-based discussion segment of the session tonight. So we do welcome comments and questions through the chat box, as you may have questions for the presenters tonight. We'll try to respond to those in live time if appropriate, but if we need to allow more designated time after the presentation to respond to questions, we'll do that as well. If we do run out of time for all questions, we can certainly work with our presenters to see if we can provide some written responses after the session as well. During the case-based discussions as well, I do just want to share that we do welcome input from you all. through those case-based discussions. You can use the chat function or raise your hand and come off mute in order to share any reflections you might have or questions that the case-based discussions might raise for you. Just important to really emphasise that because the session tonight is an initiative of a government-funded pilot project called the Strengthening Primary Care Responses to Family Domestic Sexual Violence, it is really important that we capture your feedback on how you found the session tonight, because it goes into a national evaluation of all the activities that are delivered as part of this funded pilot. So do take the time to fill out the evaluation form. You can scan the QR code to have it open now, or you can respond to the link in the chat following the session as well. It'll only take 5 to 10 minutes to fill that out. Important to just mention that whenever we're talking about family domestic sexual violence and topics related to this public health issue, we do note that this can be sensitive and an emotional topic for a lot of us. And these conversations can be challenging. So just know that you're not expected to share anything that feels uncomfortable, or at any time you just need to take a break or step away, you're welcome to do so without explanation. We do want to just remind everyone to approach the session with openness, empathy, and compassion for not only yourself, but also for others in the room. And we just want to remind you of some important phone numbers and resources that are available generally. And I know our presenting team will have more information on resources and support after the session. So it's really my pleasure now to introduce our presenters for tonight's session. So we have Kate Anglin and Penny Zakil from the Sexual Assault and Family Violence Centre in Geelong. Kate Anglin is a counsellor advocate and a registered psychologist who's been working with the SAV Centre since 2023. Kate currently supports young people and their families who've been referred to the SAV Centre for their harmful sexual behaviour program. Prior to this, Kate was a psychologist within the NDIS and for many years has worked with custodial and community forensic settings, supporting adults who have engaged in violent and sexual offending behaviour. And Penny Zakil has worked with the therapeutic services team of the SAV Centre since 2017 and in roles including counsellor, advocate and team leader, supporting victim survivors of sexual and family violence. Alongside her clinical work, she's passionate about developing and delivering training for professionals on a trauma-informed practice and responding to disclosures of sexual and family violence and fostering respectful workplaces. Over the past 12 months as well, Penny's been working with Western Vic Primary Health Network's project team on family domestic sexual violence and has been implementing the Family Domestic Sexual Violence A-Lives training and support program. It's my pleasure to hand over to Kate and Penny in order to commence tonight's presentation.
Thanks very much, Emily. And thank you to everybody for coming to the session and being here with us tonight after what is presumably a long work day already for many of you. So thank you very much. Kate and I will be with you for the next until 8 o'clock to go over the topics tonight. So as Emily said, please, any questions that you think of at the time, please drop them in the chat. We're happy to respond to those. If we don't get to them as we go through the session, we will be able to respond to them afterwards. So as Emily mentioned, Kate and I are from the SAF Centre in Geelong. So we are a community-based not-for-profit service offering a range of free and confidential trauma-informed sexual and family violence services across the Barwon, Wimmera and southwestern regions of Victoria. Some of the services include counselling, crisis support, training and primary prevention. The SAF Centre is part of a Victoria-wide specialist sexual assault sector. So you might have heard of CASAs, Centres Against Sexual Assault. So we are sitting within that network and there will be local services to you if you are in Victoria. And just echoing again Emily's note at the start of the session that some of the content that we're going to be discussing tonight can be tough at times. So please do whatever you need to, step out, take a moment and come back when you feel ready. Thanks, Kate. Okay, so just a few learning outcomes that we've got tonight. Hopefully we'll get through all of these. We are going to provide some definitions so we all have an understanding of what harmful sexual behaviour is, how we distinguish between age-appropriate and harmful sexual behaviours, how the HSB type presentation may come across in primary healthcare, understanding Victorian mandatory reporting obligations. If we do have people from interstate, that will be different for your region, but for Victoria, we will provide that information. Responding in ways that reduce shame and increase safety. Identifying appropriate referral pathways and therapeutic support options across the Western Victoria region, and applying learning in those case-based practice discussions that Emily mentioned earlier. We will sort of start with more of an information kind of part of the session, and then we will move on to some of those more practical kind of options. We will provide, you'll get a copy of the slides from tonight, and we will provide all of the contact information for local services and reporting and all of those pathways that you need. It is later on in the presentation, but you will have all of that info. Okay, so harmful sexual behaviour, or HSB, as you might hear it referred to it a bit tonight. Why does this matter in primary healthcare? Why is it important for you to know about this? Increasingly, what we're finding is this is a behaviour that we would recognise as occurring amongst young people, and it's increasing in Australia, what we're finding. So around 1 in 5 young people have reported being sexually abused or assaulted by another young person. We know that disclosures are much more likely to occur, or indicators becoming obvious outside of specialist services. So we can deal with that once it comes to us, but much more likely to be observed outside. We know that early intervention and support is really important. So non-shaming responses lead to really significantly better outcomes, better engagement with interventions and support, and just better outcomes all over. And we know that children and young people who receive that appropriate support and intervention show much lower rates of recidivism or repeated behaviours. So the earlier we can get in there, the better. Thanks, Kate.
So we thought we'd say at the start what we mean by harmful sexual behaviour. So when we're referring to this, it is talking about children under the age of 18, and we're talking about behaviour that's developmentally inappropriate, might be harmful towards themselves, but also towards other people potentially. And it might be coercive or harmful or abusive towards another child, young person, or an adult in their life. We do, sometimes you might see there be behaviours referred to as problem sexual behaviours and harmful sexual behaviours. It's not black and white, but there is a little bit of a difference when we're talking about these in terms of age. So typically problem sexual behaviours might be for those under the age of 12, and harmful sexual behaviours is that adolescence to later adolescent age range. Again, age is not the only thing we kind of look at when we're looking at the difference between problem sexual behaviour and harmful sexual behaviour. We're considering things like severity, level of harm caused, and what that young person has had the opportunity to learn about or know about already at this stage. So yeah, just you may kind of see those two phrases thrown around, and there is a little bit of an age part to that. Just wanted to show this slide and talk a little bit about the drivers of harmful sexual behaviour. I think often what we hear is or see distress around young people being the victims of sexual harm themselves, and that is the reason for harmful sexual behaviours occurring. We know it's a lot more complex and nuanced than that, and so this is just a little bit of a diagram to show some of the things that us as a service might be looking at and seeing and considering. So, you know, we've got this iceberg metaphor that's kind of used in lots of contexts, but the sexualized behaviours are those observable behaviours that the families or systems around that young person are seeing, or the young person seeing themselves. And then underneath, we've got several layers of things that might be happening. Trauma is often a huge consideration when we're looking at harmful sexual behaviours. We know a lot of young people who engage in harmful sexual behaviours have experienced childhood trauma or traumas in their lives. It's not always sexual trauma. It can be wide-ranging. You know, there's some examples in there around family violence, physical abuse, neglect, exposure to pornography, especially early exposure to pornography. And I guess this can really disrupt, how that young person seeks supports, how they cope, and how they form relationships with others. alongside all harmful sexual behaviour is a need. We know that it's a need-based behaviour, like many. So again, there's some examples in there, but I think one of the questions that we as a service would ask is, what is this behaviour giving them, even though it might be in a harmful or maladaptive way? And often there's a feeling state. There might be some emotional experiences that they've been managing for a while, but there's also often a feeling state that young person might be in when they engage in the harmful sexual behaviour as well. Yeah, I think I'll hand over to Penny just to talk about a couple of the myths that we often see as well.
Sure, thanks, Kate. I think we just thought here, we can see here that the image just gives a really good idea of how complex the picture actually is when we're looking at the main drivers. I think we're pretty well aware in our sector, but of what some of the really pervasive kind of myths and misconceptions around these kind of behaviours are. So I thought it was just a good opportunity to name some of those now so that we can dispel. So it's always helpful because we can go and then explain this to other people and really actually have the capacity to reduce potentially some anxiety and I guess hopefully the perpetuation of these beliefs. So it is actually a myth that someone using harmful sexual behaviour, the young person using those behaviours, has absolutely been abused themselves. I think often we see parents, understandably, having a really anxious reaction about if they see some sexualised behaviour from their child, the automatic assumption is that that child has experienced sexual abuse themselves. So as Kate was sort of showing there, trauma and sexual abuse fits in with that as well, but it's not the only driver. So we want to make sure that we're really clear that there's not just a direct link. Similarly, I guess the flip of that, just because unfortunately we know some children are victims of child sexual abuse, that doesn't mean they will go on to use harmful sexual behaviours or indeed those kind of behaviours as an adult either. Excuse me. We know that harmful sexual behaviour, these actions from children and young people, are not related to sexual disorders and attraction to children that we might see in adults. So we're really wanting to make sure that there's a clear distinction between these behaviours occurring for children and young people as opposed to adults. I guess given that kind of picture, we would understand when we see a child who is using these behaviours or a young person, we're sort of looking at this as a twofold kind of picture. So we're understanding something has happened to create this environment, to prompt these behaviours, and we also recognise that these behaviours are not okay. But given that, and given we're talking about children and young people, we want to make sure that the language that we're using when we address these things, when we speak with patients about this, when we are having conversations professionally, that the language we're using is really different than that we would use for adult offenders, really recognising that this is happening to someone in childhood or adolescence. So, for example, we wouldn't use terms like a sexual offender or perpetrator or sexual abuser, but we might use phrases like young person engaging in HSB or harmful sexual behaviour, or a child exhibiting concerning sexual behaviour. We're really wanting to sort of make a clear distinction between the behaviour and the person so that we're not collapsing those behaviours into that child or young person's identity. I know some of those ones are a bit of a mouthful, so maybe we might want to shorten some of those from child who's using harmful sexual behaviour. I'm sure someone will come up with an acronym, but they haven't yet. Thanks, Kate.
Yes, I think building on from that, I think one of the primary ways that we look at harmful sexual behaviours is through this developmental lens. So we know that for young people, we're not going to have two 14-year-olds that are exactly the same. So it's really crucial that we're considering the age and stage of that young person. So when we're looking at harmful sexual behaviours, we're considering things around the social context, the environmental context, yes, their age, but I think really crucially what that opportunities have been for that young person in their life, not only in their general development, their education, but also specifically what has their exposure been to, sexualized content or sexual education, to build relationships, to understand puberty, to understand, the law and sex and all of the things that we're building into our schools now around education. I think, there's we know really that there's a lot of differences, between an 8-year-old and a 12-year-old. In adulthood, that age differential is not going to be as significant, but for children, that is quite a significant difference. And we really want to tailor interventions and responses not just to that child and their age, but specifically what is happening or has happened for them developmentally. And that's from everything from, a diagnosis such as like an intellectual developmental delay, neurodivergence, to just looking at what has happened in that young person's life to date as well. I think a really hopeful part about considering this developmental lens is just understanding the level of neuroplasticity we're working with young people. I know Penny just mentioned this as well, but we know the research tells us that when we provide an intervention to a young person that has used a harmful sexual behaviour or concerning sexual behaviour, it's really successful. And actually that young person doesn't go on into adulthood to use sexualised behaviours. So as a service system, it feels particularly hopeful to know that if we can identify and all work together to understand what's happening for this young person, it can be a really positive outcome. And I think, especially with children, they may not exactly, we as adults have language for what's going on and we can name and identify these behaviours, but often, when we talk to children, they may not actually fully understand the behaviours they're using are harmful. And yeah, we have a lot of responsibility as the system around this young person to provide them that opportunity whenever we can. So just wanted to touch on this slide. A lot of the people in the room here might have made referrals, and often it's helpful to know a little bit about what might happen after a referral is made or how things kind of end up within our service system. So down the bottom, the specialist service or HSB program, that would sit with us as the sub-centre. So when we're using that phrase, that's a service like us. Penny will talk to some of the services within our region a bit later, but I guess just talking from our services perspective initially. But I guess what happens first is identification of a harmful sexual behaviour. That might be because a young person has been the victim survivor or has had harmful sexual behaviours used against them. Often it might be that the person using harm has come to the attention of someone, the family themselves, school, can happen in the GP clinic, other professionals. And once that happens, there's a couple of different pathways that can take. So with everything, it's initially safety, what safety needs to be considered and who needs to know. So we have pathway into child protection or to socket, our police force down here. They will assess safety and understand the correct responses from a justice system response as well. You can come through to us directly or through to child protection and socket through a secondary consultation. And we really, really could not encourage that more. What we're here for, to really take those calls and support anyone that has some questions or just wants to know what they're seeing or if they should explore something further. We're really, really open to that secondary consultation. And we also have families with their young people referring directly into our service as well. So it doesn't come from another service, it can come directly from families. We do see that too. And I guess, via secondary consultation or through CPS and socket, it can come via a referral to us. Often that's voluntary, and wherever possible, that is a voluntary referral. There is a mandatory referral pathway, and I won't go into a lot of detail about it today because it could be a very lengthy conversation, but they're called therapeutic treatment orders, and they are separate from, I guess, the criminal justice system. But usually it occurs when there might be some barriers to that young person consistently coming to our service and accessing the intervention they need. So that is an option. And I guess at any point here too, I think something I would just like to clarify is that we always ask the question, is there enough safety? So all of the services like CPS and socket and ourselves will ask that question. So families won't always end up with us. There is exit points along everywhere in this diagram. Yeah.
Yeah, we really want to make sure that people are getting the right level of support. So we're sort of sharing this to, to give a sense of this is what might something might look like, or what things could look like. So if this does come up in any kind of appointments that you might have with patients, just to have a sense of the overall system. Really, I think what maybe isn't quite as clear, but we would really like to share as well, is this is a really, once someone is engaged in this system and moving through one of these pathways, it's a really multidisciplinary approach. So they kind of, all the arrows look like they're going down one way, but really this is quite, it's quite reciprocal. All of the different levels are sort of working together to make sure that we are actually providing the safest, most comprehensive support that might be required here without overdoing it. We don't want to over involve where that doesn't need to happen to. So, as Kate mentioned, not all of the identified HSPs will necessarily end up with us. That might not actually be necessary. So it's just a bit of a sense in case it comes up. You don't have to remember it, but just so you've got an idea.
Yeah, beautiful. And I guess just to touch on briefly our service specifically, just a little bit of information about what it might look like if a family and young person does come into our service as well. So we have, I guess, two phases that really happen. The first one is an assessment phase. So this is so we can really work with that young person and their family and their entire support network to understand what this young person's world looks like, why these behaviours have actually occurred, when they have occurred, and with who. That is, a really comprehensive formulation that we go through and identify what specifically for that individual child will be helpful with the interventions that we then go on to offer them or provide for them as well. And like Penny said, this is a really systemic approach. So, not always, but there's often lots of supports involved. It might be that we're getting a little bit of a history from a GP, but we're often talking to, NDIS service providers, to schools, to other people that are involved in that young people's life. It can be really varied. And the program itself, I think often there's a misconception that this is like a group-based program where we have young people coming in and sitting in a room together and, it goes for 6 months over so many sessions and then tick, program done. It's really reviewed and tailored on an ongoing basis. So we have some families and young people that might come in for 3 months. We provide a brief intervention period of support, and that's what that family and young person need. But we also have the benefit and the really fantastic opportunity to work with young people and their families for up to 12 to 18 months. And that's until the age of 18, just to be really clear as well. So it can be long-term and it can be brief, and it's case by case, and we work individually with that young person and family as well. Okay, move on to the next one for you, Penny.
Thank you. Okay, so one of the key learning objectives that we had for this session was to focus on how we actually go about distinguishing age-appropriate versus harmful sexual behaviours in children and young people. So the traffic light model that we can see here is a really widely accepted and helpful guide to outline the kinds of things that we're considering when we're making these kind of distinctions. One of the fundamental considerations up front, and something that this model sets up really well, I think, is that we're not just focusing on the behaviour itself. We really want to understand the context around the behaviour. It's really equally important. I think Kate was speaking to that when we were talking about what an assessment and intervention might look like. We're really wanting to understand the whole environment to find out what is it that has contributed to these behaviours occurring in this environment at this time. So rather than asking, is this behaviour good or bad, we're sort of asking, is this behaviour developmentally expected, or is it concerning when we consider the fuller picture? So there are a few key factors that we take into account. You can see we've got the green, orange and red levels there. So first of all, we're thinking about developmental age and stage. So some curiosity about bodies or relationships can be really typical at certain ages, but the same behaviour might be concerning if it's significantly outside what we would expect developmentally. Secondly, we're thinking about things like consent and power dynamics. So are the children involved, similar in age and size and understanding of what the behaviours mean? Or is there a power imbalance here? So do we have maybe an older child and a much younger child, or one child using, pressuring type behaviours or coercion or an element of secrecy? They're the kind of things we're thinking about there. Thirdly, we're thinking, what's the frequency and persistence, I suppose, of these behaviours? So is this just a one-off incident? Is it a more of a curiosity-driven behaviour, or is it happening repeatedly, becoming more intense, or is it becoming more difficult to redirect that child away from that certain behaviour? Fourth, we're thinking about what's the impact on the child, and that can be the child who is actually using the behaviours or the child who is being impacted by that. So is this behaviour causing any distress or fear or shame? And obviously, particularly, we're focusing on, is it causing any harm as well? And is that to the young person themselves or to others? So green behaviours are typically mutual kind of behaviours. They're not distressing at all to either party. They're both engaging. Red behaviours are almost exclusively going to involve sort of harm or distress or something at that end of the scale. And the final kind of thing that we are thinking about when we're putting this together is the context and the environment. So this includes things like, what has the young person's exposure to sexualised or sexual content been? Kate mentioned before as well, access to sexual education and having the correct language and understanding of those things at age-appropriate points. What are the family dynamics, trauma history potentially, or any other vulnerabilities that might be influencing the behaviour at this time? So when we put all of that together, what we get is this kind of model. And these are the sort of things that we're thinking that would broadly define the different categories. So we've got the green behaviours that are developmentally expected, they're led by curiosity, they're mutual, and they're really pretty easily diverted. Orange behaviours is where we start to raise a bit of concern. So they might be things that are outside that typical expected developmental range. There'll be behaviours that are a bit more persistent, and they involve some kind of imbalance, power imbalance or age or something. And red behaviours are pretty clearly harmful. There's an element often of coercion or developmentally inappropriateness to whatever is happening. And the red behaviours are where we're looking at there needs to be a really immediate response. So I think if we take anything from how we make this decision, rather than just giving a whole lot of examples, which we will do, this is how we might decide which behaviours fall into which categories. And we just want to sort of remember from this, I guess, that what we're talking about is pattern and context. These are the things that are going to help us determine which category we might put them in. It's not just the behaviour in isolation. So really quickly going to skip past this slide. We're going to provide a handout to this. And once I've moved on to my next bit, I will pop in the chat a couple of links to where you could go and download this now, but we will provide it because you absolutely can't read that. It's just a really big overview of how the traffic light system works. So obviously those red, green and orange behaviours broken up, if you can even see that, by age groups, because this is a model that covers the whole age spectrum for young people. It's a really great resource. Anyone who's done the FDSV and CSA training that Emily was talking about earlier through Western Vic PHN, we provide this. It's a really great resource to have on hand in consult rooms that you can use with parents or patients to really clearly identify, hey, these are the things that are green behaviours. This is where we might be more concerned, and obviously we hope we're not in the red space, but we are. But being able to really clearly identify the green behaviours in particular can actually be a really great way of reducing some anxiety, which we really recognise as soon as anything, is, I guess, a young person is showing any kind of different sexualised behaviours. Obviously, there's concern for parents and caregivers and schools and things, even if it's not actually harmful yet, depending on the age of the child. So I guess we're just going to break them down a little bit and just have a look at, okay, what are some of these behaviours that we would consider green behaviours at different age points? Just to get a sense of, I suppose, sometimes we want to distinguish between these are non-harmful, but they may still be unfamiliar to some people. And that in itself will cause an element of concern, potentially. So, for example, I'm not sure that a lot of parents would necessarily if this was their first exposure to things and maybe a first child, if a 18-month-old, 2-year-old was engaging in unself-conscious masturbation, that might be something that is actually quite concerning to a parent. And if we think about the myths that we talked about earlier around, if my child is exhibiting these behaviours, it means they've been abused themselves, we can understand how the anxiety is going to skyrocket really quickly. So being able to provide some guidance around this is actually really crucial. What we might be seeing is unfamiliar for sure, but actually, if we can look at it and also think about those contextual factors of green behaviours around, child's really easy to divert from this behaviour, there's no harm involved, there's no coercion, we can really see that this is just a normal curiosity-driven, age-appropriate behaviour. We can see that there are different examples for different age groups. Once we're getting into sort of 10 to 13-year-olds, hugging and kissing and touching with known peers, really normal. Exhibitionism, flashing and mooning each other. I don't know if anyone's got 10 or 13-year-olds, but, we're pretty keen on some of that sometimes. And then obviously as we get to, 14 to 17-year-olds, we're sort of thinking really that if we think the age of consent, we're talking in Victoria is broadly 16, some of these things are going to be really different for 14 and upper adolescents, 16 and 17-year-olds, certainly. I think what we just also want to recognise, I suppose, with this, that it potentially is more of an impact with the green behaviours. There's the unfamiliarity of these things that might cause a bit of concern from parents. We also recognise that different families and schools and cultures and religions and countries have so many different beliefs and feelings about any kind of sexual activity at all. So we really do recognise that, and that may play a role here too. And it's not to say that any of those things are wrong in any way. It's just if we have something like this that we can show these things they're not problematic. Understanding beliefs, this is not from a developmental perspective, this is considered a normal behaviour and there's nothing to be concerned about in that way. I think those things are really important to be able to explain and to have something like this to back that up. Hopefully helps that. Okay, I think I'm done. Over to you, Kate.
Thanks, Penny. So just going to briefly touch on, I guess, these orange behaviours, and I think this is often where we'll see the most secondary consultation happen. Sometimes these can feel a little bit less clear. We've got people saying, is this really what's happening? Is this actually okay? And, sometimes they can be a bit tricky to understand until we follow through on some curiosity and ask some questions of the families and young people sitting with us in different contexts. So, let's say we have a 4-year-old in kinder pulling another child's pants down or skirts up against their will. I think what I really see in the orange behaviours is this is where we have an opportunity to provide some brief redirection or some advice and support and really move away from this trajectory, hopefully into red behaviours as well. So, you could see with something like that, you could easily redirect and provide a little bit of education to a 4-year-old around why we don't do that. And it could be, an easily diverted behaviour. But I think, as we move through the age groups as well, you can kind of see some of the themes throughout this, the words persistent, redirection, we've got, 10 to 13-year-olds where we're talking about sexually transmitted infections or pregnancy. So, this could be, a lot of anxiety or concern from a young person asking a lot about these things. Which we'd want to be, wave a little bit of an orange flag and have some caution about it. We've got like a 10-year-old showing a level of anxiety about some of these things. And it might be coming up for some people in the room already, but, when you look at some of these things, there's some that seem clearly, more about, who might be the harmed and who might be using the harmful sexual behaviours in some contexts. But in other contexts, it might be like, well, are they the person that is actually being harmed by the sexual behaviour rather than the person using the harmful sexual behaviour? And yeah, it is not always significantly clear especially if we're talking about something like a young person coming in wanting to get STI checks or talking about pregnancy. But I think what these behaviours are telling us is be curious, maybe ask some more questions about what's going on for them here in as sensitive way as we can. And I think, we would all do this in a sensitive way, but not knowing maybe what the dynamic looks like, you want to be extra cautious about how we're asking questions and exploring some of these things. So I'll move through this one. And then we have our red behaviours. So these, like Penny said, are the behaviours where it might feel a bit more clear that there is harm being caused here. So if we look at something like in the 0 to 4 year age range, if we have a 4-year-old that is simulating sexual touch or sexual activity that involves any kind of content that you would think an adolescent or an adult would be thinking or talking about or showing, then that is a cause for concern. So, whilst in the green behaviours, we might have a young child that is kind of doing unselfconscious masturbation or, touching their body. Here, we've really got, talk or simulation of sexual scripts or dynamics that are considered more adult or older that, raise some concern for us. 5 to 9-year-olds, we've got, children really trying to access, bathrooms or rooms where children are changing, showering, grooming, and, they're getting distressed or frustrated when they can't do that, or being secretive about some of those behaviours. And again, if we've got a 9-year-old that's presenting for a STI infection or we've got concerns about that, it's pretty clear. We've got a 9-year-old that under no circumstance can consent to any sexual behaviour, so they have been harmed, or, maybe engaging in sexualized behaviour with another child. So we want to be really questioning that. And then up into our older adolescents as well. What I find really interesting here is when we start talking about early adolescence and older adolescents, what we can often see is some clear power differentials happening when it comes to, age and stage. So it might be that we've got a 13-year-old that is seeking out sexual contact with an 8-year-old, for example. And so, inherently, we've got a bit of a power dynamic differential going on here as well. And then 14 to 17-year-olds, I think this is where, it's really tricky with the pornography part. And I think this could be a whole presentation on itself. So we won't have heaps of time to go into this, but I think like Penny said before, I think being curious about sex and wanting to explore things like sexually arousing material, whether that's pornography, magazines, pictures, whatever it is, or sexting with their friends, the curiosity in and of itself isn't a concern, especially when we're getting into older adolescents. But when there's themes or attempts at coercion or dismissing consent or not seeking consent, that's, I guess, where we start to see that it's a harmful sexual behaviour, or if they're becoming preoccupied with pornography, it's impacting on their capacity to go to school, spend time out in the living room with families, these kinds of things, then we understand that it's a harmful sexual behaviour. Again, can be harmful to themselves and they're in development with relationships and identity, and can be harmful to other people as well. And I think, we've got the overlay of, our criminal justice system here too, where the consequences for our middle adolescents and adolescents becomes much more significant. I guess a caveat to point out as well that's happening in the context for them. Wow. Did you want to add anything else to that, Penny, before?
No, the only thing I was thinking as you were talking was also just this is just a selection of behaviours that we chose from each one. The actual sheet that's unreadable on the screen has got a lot more examples to go into, but this is just a few. Okay, so I guess with a bit of that background sort of understanding of, how would we define these behaviours, what are we talking about here, and then this idea, the traffic light model to help us distinguish between, age-appropriate behaviours all the way through to those more harmful red behaviours. What are we doing about this, or what might we be noticing, and what are GP responses in this space? So types of clinical indicators that you may notice. Look, some of these are going to really overlap with broader sexual abuse or sexual assault type presentations. So some of these things are clinical indicators that would be consistent across both. But things, physical indicators, and again, so some of these are going to be more significant depending on the age. But things that may raise a bit of a red flag for us might be things like really recurrent UTIs, STI testing, either really repeat STI testing or that testing in really young adolescents, or hopefully not in children before that, but and any kind of physical injuries. So that might be ones that would be clearly of a sexual kind of nature or to the genital region, but it could be other injuries as well, but any kind of patterns that we might be looking for there. Behavioural indicators, we would sort of distinguish those between, I guess, non-sexual and sexual. So non-sexual, to indicate that something is obviously not right there, we might see things like, changes to eating patterns, or the way someone dresses, so starting to wear, really oversized baggy sort of clothes when that wasn't their normal behaviour before. Increased risk-taking behaviour, school refusal, any of those things that are causing concern for a parent or a caregiver potentially, that's indicating something's going on. Would we look at any one of those things and say this is definitely HSP? Not necessarily, but it's going to give us an indication that something's happening there. And then some of those more, I guess, sexual behavioural concerns might be the increased sexualised language, questioning, behaviours, interests. Again, when we think about them around whether they would fall within what we might think of as age appropriate, and thinking about those other contextual factors, I guess particularly adding that lens and thinking, okay, is that is it curiosity driven? Is it easy to divert from? Those kind of things might be follow-up questions that we might be able to inquire around. Some of the other behavioural things that we've got listed there might be behaviours in other children, so siblings or other children refusing or avoiding contact with a particular child or young person. It might be pornography concerns, which Kate talked about, or any of that image sharing and online coercion, those kind of things. Sometimes these will be things that will be potentially more likely to be brought to your attention by a concerned parent. Might not be things that we're thinking you would necessarily notice or have any indicators for in an appointment, but they may be things that a parent or caregiver may raise. The other thing we just always want to note there too is that indirect disclosures or indicators in any of the sexual assault spaces whatsoever, but including HSP, indirect ones can be really common. So we know that people are, not very likely to disclose voluntarily any information in this kind of space anyway. They're much more likely to do things indirectly. So if we can ask some direct questions, that's great. Indirect disclosures might be things like, is it normal if this happens? Do you see lots of kids or young people where this is occurring? Is this something that you've heard about before? Something where we get a sense that someone's asking a question for a reason, but they're doing it in a really general or externalized kind of way, so that there's sort of, it's almost like a testing space. Is this going to be okay? How is this person going to respond to me? And is this going to be okay to talk about? We know that, shame and stigma around these issues is hugely significant, and we don't want to downplay that. So I guess the things that we were talking about before around the importance of the language that we choose to use and the way we might respond to these things is really pretty crucial. The first disclosure in any of these spaces is the most important, and is really going to determine whether someone is going to go on to seek any kind of support, whether it's a child that has been harmed by these behaviours, or whether it's a family where these behaviours have been identified with one of the children using them. So anything that we can do to really remember that non-shaming, non-judgmental language, to explore these things further, and then to provide options and supports going forward, means the family is much more likely to engage with those interventions and support and see that, you're approaching it in a really non-judgmental, non-shaming way. It means they're more likely to have the capacity to take that lead. Absolutely, Emily. Yeah, Emily's just popped in the chat there. I imagine it's extremely important to be non-judgmental to the family involved. 100%. As Kate said before, we really acknowledge something has happened here, but we don't know what that is. We don't know where, certain factors have created sort of pockets of influence, or what other things are happening in that entire family's life, in that child or young person's life. So we're really wanting to approach this with genuine, sort of curiosity and empathy, and ensuring, we're remembering we're talking about children and young people, and we want them to engage, because we know that the success rate from these things, from actually having a really positive intervention here, success rates are great. So we really want to, do whatever we can to support a really positive engagement in that space. But yeah, sometimes it is kind of shocking when you hear some of this information straight off the bat, or you weren't expecting it. We absolutely get that. So I suppose we'll keep saying this again, but services like ours and the other causes that we will mention that also cover the Western Vic PHN region, we're always available for secondary consults. So you never have to, if you do notice some of these indicators, don't ever feel like you have to handle this on your own, or that you need to assess things necessarily. We will provide some guidance around what we might look for, but you are not on your own in this. We recognise, this is an area that is not familiar for a lot of people, and we absolutely don't expect that people will be able to just jump in and do this on their own, and we are happy to provide support and any guidance that we can. Okay, so what is the response then? So we've sort of mapped it out. We've got really, obviously, in any situation that we're thinking about these kind of any kind of sexually abusive behaviours, really, managing risk is always the first and foremost. Reporting, referring, and supporting. So the way that we do that is really important. So I think all primary healthcare practitioners will be aware of things like trauma-informed approaches. Making sure that the language we're using is falling within that we are giving people as much choice and agency as we possibly can, being really transparent with the information that we are providing, using those really calm, clear language kind of responses and exploration if we need to do that. Really behaviour-focused framing for anything too, so really making sure that our language is focusing on behaviours that are occurring, not on labelling children or young people involved, and that real safety emphasis. We're just wanting to make sure that actually everyone in this environment is safe. So thanks, Kate. And you just flip to the next one. Thank you. I'm going to just go through the first couple here. Look, the pinky purpley column for managing risk, really what we're talking about here is if there is an imminent risk that has been identified and we need to kind of have that really emergency sort of response. It is really unlikely that this is something that would present in primary health practice. To be honest, I wouldn't really expect that, but we obviously want to make sure if there are children or young people in immediate risk, that we do need to check that child is safe when they're going to leave the space if they're with you. Are there any protective adult caregivers who are aware and actively protecting? And if we can't establish those things, we need to be calling the emergency services or making some kind of plan to make sure that that child is safe to leave your practice that day. Kate's going to refer in the next slide to a couple of the things that we would include in terms of safety planning, not because we expect you to do it, but just so that you have a sense of the kinds of things that we would be thinking about in those initial stages. So unlikely, that first column, but still necessary that we talk about so that we know what we need to do. The reporting, everyone who is a GP in Victoria knows that we have mandatory reporting obligations in Victoria. So I'm going to put a link in the chat in a moment, but if we have a reasonable belief that there is a risk to this child, generally for physical abuse or sexual, we need to make a mandatory report to child protection. So we've got links there. We'll provide contact details as well for the relevant Child Protective Service numbers and local socket, so the sexual offences and child abuse investigation teams for the particular areas that you might be in that cover the whole region. We've found those. Again, I think sometimes we have this idea that a mandatory report is going to be really clear, and sometimes it's just not. So again, this is a space where we can absolutely do secondary consults. I think even Kate would probably agree, even sometimes we do them quite frequently, probably, and still sometimes we have have consultations with each other, because sometimes it is just in fact not super clear yet. So please feel free to seek secondary consults. That might be with a specialist service like us, but you can actually also do a secondary consult. You can check in those things with Child Protection or with Socket. They will both do that too. So you never have to make those decisions off the bat on your own.
Yeah, absolutely. And, especially with us, I think sometimes it depends with Child Protection who you might be speaking to, but especially with us, it can be done in a really de-identified way. So you can feel like you can make a bit more informed consent if, it's heading in that breach of confidentiality kind of direction, which can be quite challenging sometimes. So, we don't need necessarily all the details of people initially to do secondary consultations, just to flag that. But I guess the other role that GPs can be really key in is on referring. So it might be that you're able to provide information to families or potentially an older young person that you're working with about the fact that the supports actually exist. Here, for example, with the SAV Centre, you can refer the young person that may have been harmed or the person that, is flagging that they might have some concerns about their own behaviours to our service, and really provide some reassurance that the response they're going to get is based in wanting to support them, wanting to support safety for everyone involved, and just make sure that everyone is okay and getting the right direction that they need. And yeah, exactly. There really is no wrong door. I think obviously when you call in Child Protection, they typically ask for some specific information, which if you have, great. But, I think, across our services, everyone just wants to make sure that we can be aware of and support when things might be happening, especially for children around harmful sexual behaviours. And, it might be that the young person doesn't, the parents might say, oh, well, my young person is, definitely not going to go in for counselling. There's just no way they're going to talk to anyone and get support. They can reach out as families themselves as well. There's nothing stopping, parents from reaching out for support, even if that young person's not ready to engage in a therapeutic kind of response, like with our service, for example. And the secondary consultation, I kind of won't go over that again, but any professional can reach out to us and talk through things. It's tricky, but I think, thinking about the ongoing role of GPs and how they can continue to support families. So, I think seeing families regularly, and then once you're aware that things are happening, you're in a really great position to check in with families about those things incidentally when they come in for regular appointments. If someone's coming in and we know that part of the pattern or the identification's been, pregnancy concerns or lots of STI checks, and they're coming in again, there's an opportunity to provide some ongoing support there. Bring it up with the support system that hopefully is in place there as well. And I think that ongoing education around age-appropriate sexualised behaviours, there's nothing stopping, GPs pulling out that traffic light system, especially when it comes to families. There might be, questions, and a lot of those behaviours kind of feel like they're sitting in that green section, just giving them that and pointing it out and reassuring and normalising the emergence of sexual development, because for a lot of families and parents that can be a point of concern, especially the more we talk about it in the media and in our screens in lots of different ways. Is there anything else you wanted to add to the support section there, Penny, before?
Well done. All good.
So I just wanted to briefly talk about safety planning considerations. And again, like Penny said, it's not that there's an expectation that, in a GP room, safety planning is going to occur in a comprehensive way, but these are questions that we would generally ask a lot of people or explore with a lot of families and young people, especially initially. The idea is that, safety might need to be quite, tighter or include more supervision or more oversight while things are being assessed. And there's, nothing stopping anyone that's involved in that young person's life to explore some of these things to create a better understanding of what's going on for safety. It's often like a a puzzle that, gets formed over multiple conversations and multiple settings to fully understand the level of safety that young person or the young person being harmed has in their life. So some of the things we might look at is what is it that adults need to know and who needs to know. So is that child spending time at a grandparent's house, with other children, with extended family, with friends? Can access to online tech be strengthened? This would be a contentious one, but the devices need to be taken out of the room for a little while. Is there some online, tech blockers that can be put in place, especially in the short term, especially if that's part of the story? Who is best placed to talk to the young person that's been harmed? Because I think wherever we can to make sure there's their voice around like what they need to feel safer or more comfortable. And obviously that conversation is going to look really different with a 5-year-old versus a 14-year-old. But I think knowing that at least someone's offered an opportunity so that young person knows that they've been seen and that the thing that is happening in their life is being responded to by the adults around them. And then there's some practical things. So often we talk to families around, if there's older kids looking after younger kids, helping them get dressed or with their bath, time and things like that, we're going to remove that. Some families are a bit more flexible with things like, nudity and things around the house. So we would be, wanting to put more barriers or, reduce that happening in the home. So just to give you simple things like, we get changed with the door closed. No one goes into the bathroom while you're in there, and adults only, safe adults only are, and we name them, who are going to be the ones that look after you when you get changed, when you have a bath. No one else can. And then just some additional guidance that I think sometimes isn't often thought about, but, it's not about standing over kids' shoulders because sometimes, we don't want to increase the anxiety for the kids, but it's around, okay, well, when we watch TV or play games, we don't do it under blankets anymore. We're not building forts and spending time without an adult in a fort, for example, or, they're not spending lengths of time in a tree house out the back. I think it's just around making sure that parents are aware of what's going on and, can actually have a visual of what's happening with kids' bodies, especially when they're younger, is really important.
Absolutely. So I'm going to kind of fly through these a little bit. We just want you to have, so there's going to be a slide here for each of the separate services. We just wanted to acknowledge that we've covered the region of the Western Vic PHN to note down that the specific services that would be able to support you, I guess, from that specialist service perspective. So the following slides are going to have additional, so we'll sort of stop on one, but they're all going to have how to contact. That's okay, you can go to this. Thanks, Kate. How to contact the services. So you'll see that the staff centre, we cover both the Geelong, Barwon area and Horsham and the Wimmera district. How to contact, how to do secondary consults and whether referrals are taken or whether we, want the clients. Generally, it's the clients are being supported to access rather than referrals, but some causes have different options. And also what the after hours contact will be. So that's going to be on every slide for all those services. So you can see with the SAF Centre, we've got Southwest Healthcare, so Southwest CASA in Warrnambool. And the next one is Ballarat CASA. And that should pretty well cover most of the people who fall under the Western Vic PHN region. And that information will be in the slide pack so that you can contact the services as you need to. You don't need to madly scramble things down now. Okay. So, yes, case study. Okay.
Yeah.
Yep.
Can I just really quickly answer that question actually before we get into it?
Go,
It just popped up in the chat. No, I think if a young person who's using harmful sexual behaviours is going to get support, they have to be 17 and not yet 18.
Mm-hmm.
But any person who is saying they've been harmed by a sexualised behaviour, no age limit.